fairly large EMS conference in Port Aransas. I don't know, it was like 100 people there maybe listening to me present this. And so basically it's titled Large Vessel Occlusion Stroke Screening Tools and How They Influence EMS Treatment and Transport Decisions. And so, the history of this is back in 2019. I gave this presentation to Life Care actually at the time. When we started using this in the field. And I actually sat on a committee that helped form the regional stroke plan for Dallas-Fort Worth. They also helped incorporate this. And so, I think it's pretty important. And so, I obviously have no financial disclosures, but I'm always looking for deals. So if anyone wants to strike a deal, just let me know. But the AHA actually has a lot of resources. Pieces of this PowerPoint were adapted from some of the stuff that they had published for EMTs and paramedics. And so if anyone wants this presentation, my email's right here. I'm glad to share it with whoever wants it. Several people emailed me and asked for it when I presented it in Port Aransas. But this video is kind of funny here because the AHA has like a rap song about the fast, for stroke screening. And so I thought that was kind of odd. And it has like 800,000 views. So I think that's even more odd. But yeah. And so kind of the game plan for today, this will only take about 40 minutes. And so basically what we're doing is we're taking this algorithm over here, right? And I guess I can draw on here. We're taking this algorithm over here and we're going to try to make sense of it. Because if you just have this algorithm in your protocol book, we don't want to be cookbook medics and start searching through the protocol book. We would rather just understand the hows and whys of how this works. And so we start off, we're talking about why is stroke important. We talk about some epidemiology things. We discuss the different stroke types. We discuss LVO screening tools. We discuss stroke treatments. We discuss stroke hospital capabilities. And then we discuss the treatment and transport algorithms. And we finish with a couple of case studies. And so these are just some numbers, right, that I think are really important. And so a stroke is a medical emergency, right? Stroke occurs when blood flow is either cut off or is reduced, depriving the brain of blood and oxygen. And so about 800,000 strokes occur in the U.S. each year. It's roughly the same amount of heart attacks, interestingly. And so they're pretty equal. And when you think about it, they're both cardiovascular disease issues. So it kind of makes sense. Stroke is the fifth leading cause of death in the United States. Stroke is a leading cause of death of adult disability. And so something to think about this is these patients, they don't get to go home, right? They go to the nursing home. They usually don't go back to the quality of life that they had. And so an important concept, pathophysiology of the central nervous system is it does not regenerate outside of childhood. And so when the brain or spinal cord portions of it die from a stroke or trauma or whatever, that's it. It's done. It turns to scar tissue and it will never come back. And so that's an important thing to know. These patients tend to not get better. And so that's to me is the most tragic part of stroke care is like these patients don't go back to what they once were. And so on average, every 40 seconds, someone in the United States has a stroke. And so about 7.6 million stroke survivors are living in the U.S. right now. And something to be aware of, and we're seeing this more and more common in younger people, is stroke crosses all ages, racial, ethnic, and socioeconomic backgrounds. Now, obviously, older people, older blacks, tend to be more at a higher risk of stroke, but it doesn't really matter. If you're rich, poor, old, young, you can have a stroke. Now, this is an interesting schematic from the CDC that looks at what they call the stroke belt. This is called the stroke belt, and we're right in the middle of it. And so, what you can think of the cultural. So, there's a lot of black people in this area. One, and then two, the culture of the South. We fry a lot of food, lots of butter, lots of sweets, right? Smoking, things like that. They contribute to a stroke. Okay, and so. We'll talk about the different types of stroke. So we're going to briefly cover hemorrhagic stroke, even though this lecture doesn't really focus on hemorrhagic stroke. I think I'd be remiss to not cover it. And so hemorrhagic stroke, so we think of the word hemorrhage, what does that mean? It means to bleed, right? And so this is when you have bleeding that's causing a stroke. And so a hemorrhagic stroke accounts for about 13% of strokes are caused by a hemorrhage, okay? So roughly 1 out of 10. And so where we typically see this is breakage by a blood vessel within the brain. Okay, and so you can see that's what they're demonstrating here. You have a vessel that becomes weak or aneurysm where it balloons out like this, and then eventually it can rupture. And so depending on where it ruptures, what layer of the meninges in the brain, those are different types of strokes, but generally that's what's happening here. And so Remember, an aneurysm looks like this, right? It's the ballooning of a vessel. It can be anywhere in the body, where we tend to focus on these in the abdomen, the thorax, and especially the brain, is where we really worry about aneurysms, because these walls right here are actually very weak, and so they can rupture right there. And so an intercerebral hemorrhage is when you have brain tissue that's this is within the brain tissue, and so this is a vessel bursting inside the brain itself. So when you think of, like, with the brain, like what they're showing you here, like a lesion there inside the brain. Now, subarachnoid, this obviously has to do with the meninges, right? And so this is below the dura mater, and so it's below the arachnoid mater, excuse me. And so this occurs when a blood vessel bursts near the surface of the brain. So this is like one of the outer layers of the brain, and blood pours into the area outside of the brain between the blood and the skull. And so it'll typically fall down towards the base of the skull. And so when you do a CT, it shows like a starfish pattern. Now, this is really the meat and potatoes of today, is ischemic stroke, right? And so this is the vast majority of stroke. And so 87% of strokes that we run, so roughly 9 out of 10, are going to be this type of stroke, an ischemic stroke. And so this is a type of stroke that's caused by a blockage in an artery, stopping normal flow and oxygen flow to the brain. And so we take this a step further, and we don't really worry about this too much in EMS, but it's something we need to know, right? There's really two different causes of an ischemic stroke. The first one is a thrombosis. And remember, thrombosis is a stationary clot, okay? And so a thrombosis is a blood clot is formed in an artery that provides blood to the brain. And so, you can imagine this, if this is the blood vessel, right? And you have a clot here. As platelets and stuff come swinging by, right? They start holding onto this, and eventually this could knock off enough blood flow to where the, brain's no longer being perfused, and then you get stroke-like symptoms, okay? That's one way this happens. Probably a more common way that this happens is an embolism. And so generally this is blood clot, although it can be cholesterol, right? But generally it's a blood clot or a plaque fragment, like a cholesterol plaque, from elsewhere in the body. Most commonly, the left atrium is where we get the left atrium is a common place to get blood clots. The carotids are a very common place to get plaques, okay? And so what happens is these plaques will get busted loose, or these blood clots, and they'll get lodged somewhere in the brain, okay? And so there are risk factors for stroke you should be aware of, right? And so AFib obviously makes sense. If someone has AFib, they're at a very high risk of stroke, right? Because the top of the heart is just quivering, right? And if that blood clot, the stasis of that blood starts to move, right, you can have a stroke. Hypertension pounds the blood vessels all day long, right? And so it stretches out these water hoses, and so they're likely to get damaged, right? Tearing of the intimal layer, then you get this plaque formation, right? Atherosclerosis. High cholesterol, that one also goes along with plaque formation. But diabetes and smoking are super bad for your blood vessels. They're unbelievably bad for your blood vessels. And I say all the time to students, right? If diabetes is the consequence of diabetes is vascular disease, right? So the issues with the kidneys and the vision and the neuropathy and all those things, those are all vascular issues that just manifest in different ways. Smoking is very, very bad, and of course obesity. So those are, and think, who do we run, right? If you're on shift today, who are you going to go run? Someone with AFib, hypertension, hyperlipidemia, who's a diabetic, who also smokes and is overweight, right? Like, this is who we run, right? It's all of them in one patient. And so this is a very common finding that we get in EMS. And so this next one, I think students get really lost on this. So, sit down and hold on tight when I talk about this. But we get lost on these TIAs, right? The transient ischemic attack. So the word transient means to come and go. This is why they call homeless people transients, right? Because they come and go, okay? And so a transient ischemic attack, this is a great definition. A transient ischemic attack are associated with brain dysfunction in a circumscribed area caused by a regional reduction in blood flow, i.e. we call that ischemia, resulting in either transient or minor observable clinical symptoms. Now, the historical time-based definition of a TIA was based on full resolution of all symptoms within 24 hours of onset. What does that mean? You are not in the business of diagnosing TIAs, right? Very complicated, very difficult, very risky diagnosing TIAs, okay? This takes a neurologist to do this, someone who's dedicated their life to doing this. And what I want students to be aware of is this line right here. Waxing and waning of stroke symptoms is actually common, okay? Stroke symptoms come and go, okay? That is a very common thing. And so you'll see that just like chest pain, right? Chest pain comes and goes, right? It gets a little better, gets a little worse. You pick them up, move them the stretcher, suddenly it's better. You lay them back, it's worse. The same thing's happening to the brain. It is the same pathology. You have ischemia behind it, an obstruction, right? And so the thing is, you need to know that stroke symptoms can get better and worse. Do not confuse that with a TIA, right? Waxing and waning of symptoms is very common. Um, Identification of ischemia is important because 20% of patients with ischemic stroke present with a TIA in the hours or days preceding the stroke. What does that mean? The fifth of all the stroke patients that you're going to run next year, a fifth of those had a TIA in the hours or days prior to that big O stroke, right? So I say the TIAs are kind of like the angina before the big inline, right? Like they're the warning sign. Like, hey, something's wrong. You really do need to get this looked at, okay? Up to 80% of strokes are after TIA preventable. Thus, early diagnosis and treatment are key. Okay, and so be careful diagnosing TIA in the back of an ambulance. I discourage you from trying to do that. Now, real quickly, stroke mimics. So this is a study that was done in 2017. Basically, they took 2,000 stroke patients in this ERs in the Switzerland, and they found that 15% of these patients actually had uh, stroke mimics, right? And so the most common mimic was a brain tumor, so a neoplasm. Hypoglycemia, very common one, right? There's a great story out of Life Care many years ago, before my time, where they flew a stroke patient. Or no, this wasn't Life Care. I think this is somewhere in Palo Pinto County. They were flying a stroke patient, right? And the flight crew said, "Hey, did we ever get a blood sugar on this person?" They checked the blood sugar; it's like 22. And they're like, oh my gosh. So they have to land at Medical City, Weatherford, and AMA this patient who is hypoglycemic. So don't let that be you. You need to be checking blood glucose on all altered patients, especially stroke patients, because I couldn't imagine the flight crew trying to figure out how to write an AMA. Toxic poisonings, hysterical attacks. This is not limited to women, by the way, as the diagnosis of hysteria used to be limited to women. But no, hysterical attacks, people do hysterical things, basically kind of act out. Seizures, as you know, postictal state can look like a stroke at times. That's actually called, gosh, what's it, pulse paralysis? Uh, Jeff knows the word. I can't think of it. And then sepsis as well. Paul's palsy or something like that. Oh gosh, I can't think of that word. Anyways,
Not sure what you're
so
trying to
large,
come up with. Sorry, man.
it's after a seizure you can end up Todd's paralysis. That's what it's called. It's called Todd's
Oh, yeah.
paralysis. Yeah, where you can have this. Talking about seizures, guys. Someone before or after a seizure can present with stroke-like symptoms for a limited period of time. That's called Todd's paralysis. Now, moving forward, this is really why we're here today. That was just laying some foundation. We're talking about large vessel occlusion strokes, okay? And so break down this word, large vessels. So we're talking really big vessels, the carotids, the middle cerebral artery, anterior cerebral artery, like these really big vessels, okay, are becoming occluded. So you can imagine really big vessel occluded, really big symptoms, okay? And so the idea of this whole presentation is, well, we have these screening tools to say, oh, that's just a regular stroke, or no, this is a large vessel occlusion stroke because their treatment is different. I'll tell you more, but that's kind of the hook, line, and sinker for today. Now, this word right here, be careful using it. This means LVO. It means large vessel occlusion stroke, but the very first time I ever called in a large vessel occlusion stroke to Medical City Fort Worth, a stroke hospital, when I got to the hospital, they're like, what about the elbow? The elbow, like on the arm, the elbow. And I was like, what? And they're like, you kept saying something about the elbow. We didn't understand. I'm like, no, LVO. And they were like, oh. So anyways, be careful using slang, learn from my mistakes. So let's read this definition. A large vessel occlusion stroke, right, variably defined as blockages of the proximal, intracranial, anterior, and posterior circulations. And these account for around 24 to 46% of all ischemic strokes. So what does that mean? I mean, we're talking a quarter to half of all the strokes you've been running are this. Okay, so it's a lot. Large vessel occlusion strokes are commonly refractory to IV TPA. And so LVOs place large cerebral territories at ischemic risk and cause higher rates of morbidity and mortality without further treatment. And so, the area of a stroke that's the brain that's dying in a stroke is called the penumbra. And so that area, that ischemic area, when you block off a really big vessel, right, you're going to have a really big dying area. So you get these really big clots. And so the normal treatment for this is TPA, is what we give for strokes. I'll tell you more about this drug, but when the clot's really big, TPA doesn't work very well. And so over the past few years, an abundance of high-quality data has demonstrated the efficacy of endovascular thrombectomy for improving clinical outcomes in patients with LVOs, transforming the treatment algorithm for affected patients. So we're going to talk about this word right here, endovascular thrombectomy, and what that means, okay? And so this is what we're talking about, right? We're talking like a clot here, right, on this schematic is knocking out this huge penumbra, this huge area is getting knocked down, right? And so, you get these cells die, and so, this is obviously very bad because remember, this tissue never regrows, right? And so 64% of these patients are dead or dependent at 3 to 6 months post-stroke. That's huge, right? This is a very devastating disease, okay? Now, what we learned through this trial called the Dawn trial is that certain hospitals can go in and do something called thrombectomy. And this is where they send a wire up a artery, usually in the wrist or the groin or the neck, and they will go grab this clot and pull it out, literally yank it out. So, ectomy means to remove. So they're going and grabbing this throm, and they're ectomy, they're removing it, right? And so this has a very, very efficacious treatment, and it can be provided up to 24 hours from the last known well. And so this is out of an article by this guy, and it talks about time is brain, okay? And so this just blows my mind. And so in each minute of a large vessel occlusion stroke is left untreated, 1.9 million neurons die, 14 billion synapses die, and 7.5 miles of myelinated fibers are destroyed. That's each minute, right? And we're talking about a 25, 35-minute just transport to get to Harris downtown, right? So we're talking huge damage, huge damage when you have these large vessel occlusion strokes. So this is why time is brain. This is why you start your IV en route. This is why you don't spend 30 minutes on scene. This is why your scene times need to be less than 10 minutes, et cetera, et cetera. Compared with the normal rate of neuron loss and brain aging, the ischemic brain ages 3.6 years each hour without treatment. While endovascular thrombectomy is highly efficacious, it is also profoundly time dependent, right? The sooner you provide treatment, the better off the patient's going to be. And from the patient's perspective, for every minute faster to recanalization, right? When you pull out that thrombus and you allow blood flow back, the average patient gains a week of disability-free life. These are huge, right? These are huge findings, okay? And so this is really these large vessel occlusion stroke screening tools. And so what's very annoying is there's several of these out here, right? Like several. We're using VAN. And DFW, for the most part, uses VAN. It's the simplest one. But the American Heart Association, the American Stroke Society, right, they haven't came out and said, no, we use this one, and here's why. That hasn't happened. I don't think it's going to happen. We've been doing this since 2018, and it hasn't happened in 6 years. It's very contentious in neurology to say, well, this one's better, and all these other things. So what I'm saying is pick one of these and use it, but whichever one you're going to pick, make sure that your region's using it. If you're working in DFW, we use VAN, okay? I was on the committee when we decided to use this, right? Because Jay said, we're going to use VAN, and it's like, okay, I guess we're all going to use VAN. And so that's how it went. And so let's talk about it. So endovascular thrombectomy is a highly efficacious treatment for large vessel occlusion. Large vessel occlusion prediction instruments based on stroke sign and symptoms have been proposed to identify stroke patients with LVO for rapid transport to an endovascular thrombectomy capable hospital. These are our big hospitals in the Dallas-Fort Worth. I'll show you a map. This is very important right here. In the pre-hospital setting, a variety of scales, including the CPSS, LAMS, RACE, could be used without clear evidence of superiority over one scale over the others. And so what does that mean? As far as the data is concerned, as of today, these are all the same efficacy. They're all, no one's superior, okay? So if you're going to take one of these back to your agency, I have two suggestions. Use the one that everyone else is using, right? Your mutual aid partners, your hospitals, one. Two, use the easier one. If you look at this fast ED, lots of stuff to do. If you look at VAN, it's 3 things, right? And so if you look at LAMS, it's 3 things. So pick the easier ones is what I would suggest. Now, let's talk about what VAN is. I'm going to show y'all a quick video. I hope y'all can hear it. And so let me just play this video real quick for y'all. And This is the guy that helped create it. Let me know if y'all can hear it, if someone can tell me.
Hello and welcome to VAN training. What we're going to do today is just go over a basic VAN exam.
I don't hear anyone. So
You'll also have the PowerPoint going through the different steps. So step one in the VAN is you basically just ask a person to hold up both arms like this with palms up for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Very good. So that's the number one thing. And that is the essence. If they have no weakness, there's no drift at all, there's no weakness where it comes all the way down, or if they're not flaccid, then you don't have to finish the rest of the exam. They're VAN negative. If they do have any weakness, whether it's a slight weakness, full weakness, or they completely come down, then you test vision. So what we do is we test 4 quadrants. Please look at my nose. How many fingers do you see?
1.
How about now?
2.
How about now?
5.
How about now?
1.
And that's testing the 4 visual fields. You see, you have them look at your nose, and you basically test the 4 different areas. Right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. And then you just have them look over, make sure their eyes are even. You're looking for uneven eyes. And do you have any double vision?
No.
Okay. And then the next thing, so that's vision. The next thing you test for aphasia. Aphasia is 3 different things. Naming, what's this?
Watch.
What's this?
Pen.
That's 2 objects, and then repeat after me. Today is a sunny day.
Today is a sunny day.
And then after that, you have them follow 2 commands. Close your eyes, open, make a fist, open, and you're done with the aphasia part. If they're positive in the aphasia, they either can't name objects, or they can't repeat, or they can't follow commands, then they're positive for aphasia. And the last thing is neglect. For neglect, you just look at them. You make sure that their eyes aren't forced all the way to the right or left. If they have forced gaze, look at my eyes. If their eyes are forced all the way over like this, and they're not looking towards the right. Yeah, I'm looking at you, and they're looking towards the left, or vice. Yeah, I'm fine. I'm fine. There's nothing wrong. My eyes are all the way over. So you make sure. And then the other test is you close your eyes. Tell me, which side am I touching?
Right.
Which side?
Left.
Which side?
Both.
If they have neglect, they'll tell you only right or only left when you're touching both. So you do right, left, and both. And that is the entire VAN exam. Please feel free to contact us if you have any.
All right. So let's so this is the actual like screening tool, right? And so again, he makes a good point. So we start off these stroke patients with our standard, Cincinnati stroke scale, Los Angeles, stroke scale, pick one, right? To where we do our standard stroke screening. If that's positive, then you go into the VAN, right? And so they can be, Cincinnati stroke scale positive and VAN negative, they're still having a stroke, right? Cincinnati stroke scale says 70% likelihood if they're positive, they're having a stroke, right? Not my opinion. And so that's something to be aware of. So we start off with what we normally do with stroke patients. This is what you do. This is step 2, right? This is the next thing that you would do. And so if they don't have the arm weakness, like you said, their VAN negative exam's over. So don't do the rest of the exam. If they do have arm weakness, like you showed, where it will, stays down or it drifts within that 10 seconds, then you keep going. Now, you'll notice in the vision cut, right, he tested the 4 quadrants because this is normally what you see out of the eyes, right? But what you see in these types of strokes is something called Hanana's hemianopsia, to where you'll only see out of, like, in your right eye, the left or the inner quadrant, and in your left eye, the outer quadrant, like what you're seeing in this picture here, okay? And so that's something that is pretty important that you'll see, and that's why we test all 4 quadrants, okay? Aphasia, again, language, aphasia, this is with an S, guys. Remember, aphasia with an S, that actually means speech, right? And then aphasia with a G means gulp, right? And that's to swallow. 2 different things. Now, this aphasia with a speech, we have expressive and receptive, and he, explained that pretty well. And then this last one, neglect. One thing I want you to know is the eyes fixed to one side is a very common finding, anecdotally for me. I've seen that a lot. And so what's interesting, though, is they will look to the side of infarct, okay? So what does that mean? This lady's looking to the left, right? And so the left side of her brain is dying, but she will have right-sided symptoms, right? She'll have right-sided hemiparalysis, right-sided hemiparesis, right-sided neglect. So what I'm saying is the eyes tend to go to the opposite side of where the neglect is. So they're looking at the actual side of the brain that is dying. Okay. And so that's the Van test. It's a very easy test. I'll show you an app at the end of this presentation that makes it even easier. But it's a very, very easy test that can be done en route. You could be doing this en route, right? This test doesn't take very long to do either. Now, the study on this one is, and basically what they did is, they took this test, right, and they said, all right, well, how accurate was this compared to other ones like RAISE, FAST-AD, CPSS Van, right? And they determined that as far as accuracy is around 96.7% for the Van, right? And it has pretty good sensitivity and specificity, right? Van outperformed all the other tests for the sensitivity that says that it rules, it says, oh, you might be having a stroke. The specificity, no, you are definitely having this type of stroke, right? And the negative predictive value and positive predictive value, right? Those are all very important statistical things that you look at, okay? And so that's the Van screening tool itself. Now we're going to get into treatment. I think we're doing okay on time. So the ischemic stroke treatment protocol, right? And so as you all know, I think that there's some discourse with what y'all's book says and stuff, but this isn't my opinion. This is what the AHA is saying. Let's just go down here. We first need to figure out the last known well, right? When was the patient last well? That's the phrase we should be using. When were they last well, right? When were they last normal? Okay. And so you have to get very granular with patients, families, and bystanders on this. No, like, at breakfast, were they normal? Okay, they're normal. At lunch, they were normal. Okay, somewhere between, breakfast or dinner and lunch, they changed. Okay, well, when did you last see them? Okay, did you watch, Judge Judy at 4? They were normal then, right? And so sometimes you have to get very granular with the families to figure out when their last known well is. That is a very, very crucial piece of information to get. Okay, and so if the symptom onset, right? Let's say, oh, their last known well was at 7:30 right now at night. Oh, it was around 1 o'clock today. Well, they're too late for TPA, and so they're pushed out of that window. Okay, and so the FDA says it's 3 hours right now, but what you're seeing is most people will go up, most hospitals will go up to 4.5 hours. I actually think this number is going to continue to rise, but I'll tell you for DFW's sake, it's pretty much 4.5 hours across the Metroplex. They'll give TPA, okay? And so let's go back to the other side, right? Someone wakes up an hour ago with stroke-like symptoms. All right, they can have thrombolysis, right? So we do a CT, MRI, we start IV thrombolysis, right? And so that's how this works. And so let's talk about this drug TPA, right? You hear a lot about this drug. So TPA actually stands for tissue plasminogen activator. And so we actually have TPA, tissue plasminogen activator, occurring in our body right now, right? There's little micro clots all over your body right now. And so what this does is this naturally occurs, and it goes over there and it chews on clots, okay? And so it takes a blood clot and this just chews on it, right? And your body naturally produces this. Well, how TPA is made is through recombinant technology, so it's made in a lab. And so it's mimicking what naturally occurs in your body. So TPA is given via IV therapy and works by dissolving the clot and improving the blood flow to the part of the brain being deprived from blood flow. TPA should be given within 3 hours up to 4.5 hours in certain eligible patients of the time of first started. This is a clot busting drug, right? And so the reason we have this window with TPA, right? Like, why do we not just give this at 10 hours or 11 hours or 12 hours or whatever? Is because when you start going past that 4.5 hour mark, especially, the risk of bleeding starts rising. And the reason is the tissue behind this clot is dying. And so it becomes weak. And so, a surgeon said it best once, inflamed tissue, he's like, imagine trying to put stitches into butter. That's like inflamed tissue, right? It's very weak, all right? Compared to like putting stitches in a steak, right? It's going to, and so when I think of inflamed tissue, you made a good point. It's almost like butter. It's very, it's not very solid because it's dead, it's dying. And so the risk of hemorrhage goes up really high after that 4.5 hour mark. And so that is why that last known normal is very important. The other thing I want y'all to know is the inclusion exclusion criteria on this. So what's the exclusion criteria for TPA is if they're on a current blood thinner, right? True blood thinners, Xarelto, warfarin, Pradaxa, Eliquis, Lovenox, heparin, many more. But I want you to know, students, listen carefully to this. Plavix and aspirin are not blood thinners. They are platelet aggregation inhibitors, okay? So, be aware of that. A patient taking Plavix, I know you think, oh, that's a blood thinner. It's not. It is not a true blood thinner, okay? So that's not an exclusion criteria. The other thing I'll say about blood thinners is just because a patient says they're taking their Eliquis, they may not actually, or it's on their medicine list, doesn't mean they're actually taking it. Eliquis is around $600 a month in the United States. And so they may not be able to afford Eliquis, okay? And so just be aware of that. Just because it's prescribed doesn't mean they're taking it. And so if they're not taking it, you need to find out, when was your last dose? Oh, it was 3 weeks ago. Well, of course you're having a stroke today because you floated a clot to your brain. And so they can get TPA usually if it's within a week, more than a week especially, they can get TPA. But otherwise, if someone's taking Xarelto or warfarin and they have a stroke, they cannot have TPA. Also, current intracranial hemorrhage. This is why we go straight to the CT scanner and they scan their head. They're looking for a bleed, right? If they're bleeding, you don't want to give a clot-busting drug to them, right? You're going to kill them even quicker. Same thing, subarachnoid hemorrhage, active internal bleeding. If someone's been pooping blood, vomiting blood, right? Heavy vaginal bleeding, I don't know. You do not want to give them this drug, right? If someone has had recent surgery, right? Recent head trauma, recent bleeding, AV malformations, aneurysms, things like that, you don't want to give them this drug that is likely going to cause them to bleed. General surgery within the last 14 days. So they got their gallbladder removed 6 days ago and now they have a stroke, right? Well, they're not going to get TPA. And this last one's a little controversial. This is more so a hospital issue, but I'll have you know. Current severe uncontrolled hypertension, the blood pressure will need to be safely lowered to less than 185 over 110, right? And both those numbers have to be less than that, right? And so that's how that generally works. Now, that's what I'm talking about up here in this slide, right? EMS identification of medications, especially anticoagulants, and pertaining that really good history, past surgeries, past hospitalizations, really rapidly on scene is very, very important. Another thing I published an article on is also the importance of getting family information for consent. Almost all hospitals in the DFW region will require family consent, like they have to approve giving TPA. If you don't know, I think the numbers are around 1 in 20 patients who are given TPA will die from bleeding. And so the hospitals, of course, will punt this onto the family and say, well, you consented to this, right? So, but this can be done over the phone. And so getting the family members or the next of kin's phone number, this may just already be in your CAD, can be very helpful. Not waiting for the family to stop at the Walmart and the Starbucks and then head up to Medical City Fort Worth, right? No, but if you get that earlier to where they can call and tell them, like, hey, someone's going to call you, you need to be watching your phone, can be very helpful. And so moving forward, so this is the medicine side of therapy, TPA, right? Most hospitals carry this, but really what we're talking about here is thrombectomy. This is a very, very, very specialized doctor, right? We're talking around 16 years of training after, we're at least 12 years of training, or it's 8 years of training after medical school. So, 12 years with medical school of training, very specialized doctor. And so there's not a lot of these doctors because of that reason. They're so specialized. But what this is called mechanical thrombectomy. Is an endovascular therapy that uses a stent retriever device to remove the clot in patients with a large vessel occlusion stroke. Now, because of the DAWN trial that came out in 2019, the time window for mechanical thrombectomy is up to 24 hours from last onset. So what does that mean? These are our wake-up strokes, right? These are the people that went to bed at 9 o'clock. They were fine. They woke up at 6 o'clock this morning. They're having a big O stroke. Well, they might be a candidate. They're not a candidate for TPA. They're out of the window, right? But they are a candidate for potentially for thrombectomy, okay? Quicker treatment results in better outcomes. So the up to 24-hour window facilitates mechanical thrombectomy for more patients. But we shouldn't see this as like, we got time. They got up to 24 hours. No, the sooner the better. Okay, this is still an emergency. And we talked about why with the time is brain slide. And if the patient is eligible for IV thrombolysis, that should be administered first. We're going to talk about this. So what does that mean, right? If the patient can TPA, they should get TPA and then go get thrombectomy. We'll talk about this coming up. But mechanical thrombectomy is only performed at neuro interventional facilities like a comprehensive stroke center or endovascular capable center. So let's talk about like these different phrases. And so Best EMS did this really well where they just separated it into, do you do thrombectomy or not? Because really that's what paramedics need to know. So let's take our eyes over here, right? And these are what they call neurointervention facilities, right? So they do thrombectomy. And so we have comprehensive stroke centers on here. So if I were to tell you, student, I'm giving you a comprehensive exam at the end of this course, what does that mean? It covers everything in this course, right? Not just chapters 35 through 41, it's everything. And so a comprehensive stroke center, that means they do it all. They do it all in a comprehensive stroke center, okay? And so they do the IV thrombolysis, they do the mechanical thrombectomy, they do the coiling and clipping for aneurysms, they do it all. But there's a new thing right below these called a level 3 stroke center where maybe they don't quite do everything, but they do thrombectomy, right? So they do thrombectomy, but they might not do everything else. And so there's only 3 of these in the DFW, or 1 of them in the DFW region. I think there's 3 of them in the state. And I'll show you a map coming up. But this is really kind of our meat and potatoes. So a primary stroke center, right, is Medical City, Weatherford. This is Azle. This is, really, I don't think Mineral Wells is one, but this is THR Stephenville. This is Lake Granbury, right? These are primary stroke centers, okay? And so primary meaning the first. So this is the first place that you would go to, right? Like this is the first stroke center. And so what they do is they're really good at scanning the head, determining if it's a bleed or not, and giving TPA really, really quickly. They're really good at that. And so that's kind of what they do. And so you can also see this at acute stroke ready hospitals. The difference between these is a little bit pedantic, I think, for paramedics, but just know there is a difference between the two. But generally, as a paramedic, you have a question. Do they give TPA, yes or no? Okay, that's this one's over here. Okay. Do they give TPA and also go in there and retrieve clots? Then that's these neurointerventional facilities. And so that's what you really need to know and ask yourself between the two. And so I'll come back to this slide, but let me just show you our region, okay? This is Medical City, Weatherford, right? Primary stroke center. And in our area, right, there's like 20, well, let me think about it. There's 29 stroke centers, primary stroke centers. There's only 14 comprehensive stroke centers within TSAE. These are all going to be in Fort Worth, and they're all right on top of each other, right? And there's only 1 advanced stroke center, and I'm pretty sure that's going to be Baylor Grapevine, okay? And so, as you can see, the majority of these stroke centers are going to be your primary stroke centers. There's not a lot. But if we take a big zoom out at the state, right, like at the state level, there's only, total of these, there's only 49 of these facilities that do thrombectomy in the entire state of Texas, right? We're talking 30 million people, right? It's a lot of people. There's only 49 hospitals that can do this procedure, and they're really clustered. This map showing you a 30-minute drive to a facility that's capable of doing this procedure. I'm here, right, in South Texas. There's 2 of them down here. And so that's the first thing. Now these other ones, I don't remember the number on this. I think there's like 130 of these primary-ish type stroke centers within the state. Okay, and so this is a very important thing to know that, like, if you live in over here, you're in trouble, right? Because you're out of the care area. Now let's come to this algorithm, and we'll wrap this up and try to put it all together. So this is what I was trying to lay the foundation for, is this slide right here. A lot of protocol books just copy this from the AHA and say, this is our protocol, because it's a really, really good protocol. And so let's just work through this really quick, okay? And so you're dispatched, right? And so, you get on scene, you obtain the ABCs, you do the witness interviews, you get a phone number for consents, right? You perform physical exam and validate your pre-hospital stroke screening tool, right? And you obtain a point of care blood glucose. Remember, hypoglycemia can be a stroke mimic, right? If you don't suspect a stroke, then you need to go to another page in the protocol book because it's not a stroke, right? But if you do suspect a stroke, right? So let's say they're Cincinnati stroke scale positive, then we need to determine, okay, well, last known well, when was that? When did we discover the symptoms? Okay, this is a very important piece of information to get and to get accurately. And then we're going to perform a validated LVO screening tool. In DFW, that's probably going to be the VAN screening tool. Okay. So let's say we do a VAN screening and they're VAN negative. Okay. Then you're just going to transport them to the closest stroke center. Okay. They're still having a stroke, but they're not having a large vessel occlusion stroke. So just take them to the closest stroke center. Okay. You're going to provide pre-hospital notification, all those things. minimal on scene times, rapid transport. I didn't say lights and sirens, I said rapid transport. What rapid is up to you and your medical director. Now, let's go back over here to the LVO, right? Let's say they do have an LVO. Their last known well is less than 24 hours. Great. The transport time to a stroke center does not disclude them from getting TPA. I'll explain this. Okay. Then, and also transport to a comprehensive stroke center doesn't add more than 30 minutes. Then you're going to bypass all the other hospitals and take them straight to a comprehensive stroke center. So let's use Weatherford as an example. Let's say you're running a call right there at downtown Weatherford, right? And it's an LVO positive patient. Their last known well was, I don't know, 10 hours ago. It's a wake up stroke, right? And so I'm going to come back to this. And so transporting them to Harris downtown is about 25 minutes versus transporting to Medical City Weatherford is 5 minutes. So that 20-minute difference doesn't add another 30 minutes to their total care time. So we're going to take them to a comprehensive stroke center. Okay, that's a very likely scenario. Now, this one right here gets spicy. This one right here. I don't want to skip over it anymore. So let's read what this says. Transport time to an EVT capable stroke center does not disqualify them for thrombolytic. So let's run this scenario again. Let's say their last known well was 3 hours ago. You're in downtown Weatherford. They are having an LVO, right? And their last known well was 3 hours ago, right? But man, if we go to Fort Worth, we're going to get there at like 3 hours and 40, maybe by the time they get to the hospital and get TPA, we might push them out of that 4.5 hour window mark. And you don't want to do that, right? And so what I'm saying is if you have someone in downtown Weatherford and their last known well is like 3.5, 4-ish hours, you actually need to follow this way. You need to go to the closest stroke hospital, okay? And so the idea of this algorithm is you don't want to push someone out of the window for TPA because once they're out, can't get them back in. And so the idea is if we're going to push them out of the treatment window, you need to stop, take them to the closest stroke center. In this case, it's going to be Medical City Weatherford. Treat them, right? Start TPA, and very emergently take them straight to Fort Worth. I've done this before when I was on the ambulance. I literally stayed in the hospital. We went to CT with the patient. We started the TPA. We told dispatch we're staying with this patient. We're going to transfer them out as quick as possible. They started the TPA, and then we hauled balls to Fort Worth, right? And that was a really cool story, right? That's what it should be. When you work in good EMS agencies, that's what they let you do, the right thing. And so that's what, it's a systems of care coming together to help a good patient, right? And so the other thing that I'll add too is back on TPA, I should have clarified for y'all, the average what they call door to needle time is about an hour. What does that mean? That means when you come into Medical City Weatherford with a stroke patient, from the time they hit to the door to the time they're actually getting TPA should be less than an hour. I'll tell you, Medical City Weatherford actually hits this quite often. And so just be aware, if you're wondering, well, wow, how long does it take to, get someone in there, scan their head, read it, and give them TPA? Well, the goal is less than an hour, okay? And so that should give you a benchmark. So let's go through this one more time. You have an LVO suspected patient, right? Last known well is less than 24 hours. Transporting them is not going to push them out of the TPA window. Then you're going to bypass all of them and take them to a comprehensive stroke center. And so this is the algorithm, right? This is what I was building up. This whole presentation comes to this, is to get them the care they need. Okay. Now, this is, as you can see, the regional stroke plan that we developed a while ago. It literally copies the AHA's one. And so this is very busy. Don't read this. What happened was when we were sitting on this committee, the TSAE is this huge 19-county area, right? It's 28% of the state population, 2% of the United States population, and it's 7.8 million people. And so what we decided, wow, this is a really diverse area, okay? And so we decided, okay, well, if your county is classified as non-metropolitan, remember back here how we said it was 30 minutes right here? I circled the wrong one up here. It should be this one. But remember how we said if you don't add more than 30 minutes to go to the comprehensive stroke center, go for it. Just go straight to the comprehensive stroke center if it's an LVO. Whoops. Oh, no. What happened is, what happens if you're in Wise County or Stephenville or, Hamilton County or something like that? Then you might need more time, right, to do that. And so you get 45 minutes. And then This committee also decided that we were sitting on, right? If you're in what they call a frontier county, that will give you 60 minutes instead of that 30 minutes to bypass other stroke centers to go to a comprehensive. And so this becomes a little bit important when you consider flying and how long it takes to fly people and all the time associated with the flight. So you don't need to read all this. It's just on here in reference to encourage people to advocate in your region. And when you're a paramedic, right, go to these committees and advocate and speak up for the rural, right, the rural areas. Now let's finish off with these last two case studies and then we'll end this, right? And so I appreciate y'all's attention. So it's case study 1. So EMS arrived on scene with a 56-year-old male who's having an apparent stroke symptoms. The last known well was approximately 30 minutes ago. The patient has right-sided hemiparesis and hemiparalysis, slurred speech, and forced gaze to the left. The patient is VAN positive and takes no blood thinners and has no known contraindication to alteplase. Alteplase is the trade name of TPA. Vital signs are stable. The closest primary stroke center is 5 minutes away. The closest neurointervention center is 28 minutes away. Where do you transport the patient? Not rhetorical.
The neurointervention?
Yes, good. The neurointervention facility. Very good. Now, let's change the same scenario. It's the same scenario. 56-year-old dude, he's having a stroke, but his last known well was 3.5 hours ago, right? You can transport him 5 minutes away to the primary stroke center or 28 minutes away to the comprehensive stroke center. Where do you take them?
The primary stroke center. You don't want to push that time.
Right, because you don't want to push. Excellent. Whoever's talking, I think it's Mason. You're right. You don't want to push them out of the window. Okay. Now that's spicy stuff, guys. I mean, you got to think about what you're doing. I just told you how many minutes, in 1 minute, how many 7 million neurons die, right? 7.5 million miles of myelinated fibers. This is huge, right? Like so the idea of bypassing these facilities is very big. And so it's risky, but the science supports it. And so, I just want y'all to be aware of that. What you're doing is spicy, but with evidence, you can do it. Now let's finish with this last slide. These are some takeaways from today. I encourage y'all, when you're paramedics, to be involved with your state RAC. I got my start in administration and a lot of avocation going to the RAC, right? This is the Regional Advisory Council, so they have EMS, cardiac, stroke, peritoneal, air medical committees, where basically a bunch of hospital and EMS experts and emergency management people sit down in a room and they solve problems, right? We write policy and we vote and we hash it out, right? So be involved in your state RAC, 1. 2, collaborate with all your stroke hospitals and try to find compatibility. Again, if DFW, let me just give you an example. If JPS and Harris today said we're going to change from vans to fast ED, well, guess what? We're changing too, because that's who we transport to. So you want to be compatible with your partners, not just your hospitals, but your mutual aid partners. Early activation and notification and minimal scene times are. Leave here with one thing today. You can start your IV en route. You can do your 12 lead en route. None of that's important. You're not saving their life by starting an IV or doing a 12 lead. What will literally save their life is getting them to the hospital quickly and safely. So take them to the hospital. Patient medications and compliance should be obtained. I've touched on this. Just because it's prescribed and it's on their medication list that was written 2 years ago does not mean they're actually taking it. So you need to make sure, are they taking all these medications as prescribed? It's very important. Medications are extremely expensive. Like I said, Eliquis is around $600 a month cash pay in the United States with a discount. And so consider obtaining next of kin contact information for treatment consent to be made over the phone. I touched on that as well. This can delay it. I've seen this where they're waiting and waiting and waiting, and the family, oh, we had to drop kid off at daycare, do this and do that. If you have a phone number, hospitals will usually allow consent over the phone. Now this last one is just showing you this app right here is free. It's called the Stroke Scale for EMS app. And this is like, they have all the different stroke screening tools on here. And so this is the VAN ones and all the other ones, but you can go through here and you're like, click on it and it'll, give you an algorithm at the end that looks like this. It's either an LVO or it's not. And so it's kind of a helpful tool to have. It's a free app. And that's it.